Hi everyone, my name is Elad Mashiach, and today I'll be presenting our journal highlights video titled Quantitative Analysis of Parenchymal Effects and Flow of Large Arteriovenous Malformations. SRS of large arteriovenous malformations is associated with an elevated incidence of adverse radiation effects known as T2 hyperintensity changes in the surrounding brain. Prior studies have demonstrated that hemodynamic changes could explain these parenchymal responses. Understanding the course of these responses has the potential to improve patient care and guide future treatment strategies. In this study, performed under the guidance of Dr. Kondziolka, our goal was to understand radiological outcomes and their hemodynamic effects on large AVMs. This was a retrospective analysis that was conducted using a prospective registry of patients managed at our institution between 2014 and 2020. Our inclusion criteria included large AVMs with a nidus larger than 5 cc's who received single or volume staged SRS and at least 2 years of imaging follow-ups. In total, 25 patients fit the inclusion criteria. In the study, we analyzed AVM volume changes, volumes of T2 hyperintensity changes in the surrounding brain, and obliteration. And these variables were correlated with transit times and diameters of feeding arteries and draining veins. In this study, we proposed the VA ratio, which is the ratio between the diameters of feeding arteries in Figure A and diameters of draining veins in Figure B. Figure C is a schematic illustration of the proposed VA ratio of an AVM. Obliteration rates at 4 and 6 years were 50% and 68%. The median time to obliteration was 41 months. AVMs with shorter transit times of less than 1 second had a lower obliteration rate than AVMs with longer transit times. And the VA ratio, which is the sum of diameters of draining veins to the sum of diameters of feeding arteries, was a significant predictor of time to obliteration on linear regression. Asymptomatic AREs, or adverse radiation effects, were detected in 13 patients. Symptomatic AREs were detected in 4 patients, and all of them resolved with oral corticosteroid with no sequelae. Significant predictors of developing ARE were lower VA ratio, longer transit time, higher mean dose, and higher D95. So this raises the question, are these effects truly adverse, as so they're called, or are these effects just part of the treatment-related changes? Our hypothesis in our paper is that these changes are part of the hemodynamic responses of the subjacent brain during an undergoing adaptation process of an AVM after SRS. We hypothesized that venous congestion that precedes a successful adaptation is part of the cause of such expected surrounding brain changes. This is a 13-year-old patient with an unruptured brain AVM managed with volume-staged SRS. 2 months following the second SRS, she presented with a headache and mild right leg weakness that resolved after 2 tapers of steroids. Significant reduction in the last angiogram after 43 months is seen. In summary, transit times and vessel diameters are valuable predictors of parenchymal responses to SRS. A more quantitative understanding of blood flow to an AVM is critical for predicting treatment-related changes. At this point, I would like to thank our entire NYU Langone health team for helping us with this project, and I would like to invite our viewers to read our manuscript by using the hyperlink below.